Hemodynamic monitoring. This is chapter 18. There are different types of hemodynamic monitoring. You can have arterial line, central venous pressure, telemetry, or thermal dilution pulmonary artery catheter, which is your Swan-Ganz. And we will talk about that in just a moment. Your pulmonary artery catheter is also known as, aka, your Swan-Ganz catheter, or your right heart catheterization catheter. It is also called a flow-directed balloon-tipped pulmonary artery catheter. That's why it's usually referred to as a Swan. Unfortunately, it has not been shown to have any major benefit in decreasing mortality or morbidity by research. And so what we used to use an awful lot before 1992 has decreased since 93 by about 63%. So we still do a Swan, but not as often as we used to do. There is a picture on page 324 that shows the different parts and the positioning for a Swan-Ganz. The different types are on page 347. And page 345 shows your interpretation of the different waveforms that you get from this. But the purpose of putting in a Swan is to evaluate the patient's cardiac function, their circulating blood volume, and their response to treatment. What research has shown is that your pulmonary artery occlusive pressure, also called your pulmonary artery capillary wedge pressure, or just your wedge pressure. In other words, when you occlude the blood vessel in the pulmonary artery, that pressure there is identical to, plus or minus 1, the pressure in the ventricle at the end of diastole, so your left ventricular end diastolic pressure. And therefore, it's a really good measure of telling if your patient is overloaded or dehydrated as far as fluid is concerned. Your normal PAWP or PAOP is 5 to 12 millimeters of mercury, which is about the same thing as your central venous pressure. Yes. And to do your cardiac output, you need to use ice saline if your patient's cardiac output is abnormal. Some of the new equipment says you don't need to do the ice saline unless your patient is critically ill. And let's face it, we wouldn't be putting this in if they weren't critically ill. You can position the patient either supine or slightly elevated to a max of 45 degrees. And there's a diagram on page 351 to do that. You inject within 4 minutes this ice saline, and you inject at the end of exhalation, and then you do this 3 times, and then you take an average to do that. There's also a website that you can go to for education about pulmonary artery catheters. It's called, the website is PACEPP, all one word, small case, .org. So it's PACEPP.org. It's on the World Wide Web. And I've also included the PowerPoint that the American Association of Critical Care Nurses puts out. So that's also there for you to look at. The equipment that you need is an invasive catheter and then a high pressure tubing. That's the stiffer tubing that's used because it's going in eventually to the arterial system. A transducer, which will measure the pressure. Your flush system, which is usually normal saline with heparin, and this is done to maintain your catheter patency. They usually put about a dilutional factor so that you get 1 unit per milliliter of solution, but it could be anywhere from 0.25 to 2 units per milliliter. And that heparin solution is changed every 72 hours to every 96 hours depending upon hospital policy. And then you want to do the procedure, you need to zero the transducer. In other words, you need to calibrate it to the current atmospheric pressure. We use 0 because that represents 760 millimeters of normal pressure. You find the phlebostatic axis, which is at the 4th intercostal space mid-axillary line, and you use a level and and a yardstick to make sure that you're level, because if you have it too high, you get lower readings than you're supposed to, and if you have it too low, you'll get very high readings. There's a figure on page 357 that helps correlate the catheter position and the waveform position. It is affected by your body position. So after you change the patient's position, like if you do put them supine from being up, you have to wait at least 5 minutes if they've got normal cardiac function. And if not, you have to wait at least 15 minutes before you do your cardiac output. Respiratory effort will change the readings, so you want to check at the end of expiration for accurate readings. And there's a figure on page 350 that shows you about that. PEEP, if they're on a ventilator, positive end expiratory pressure, if it's greater than 10 centimeters, will artificially elevate your occlusive pressure. So you need to check the trends then for that patient to find out what's appropriate for them. As I mentioned, your patient position is accurate at 0 to 60 degree elevation, as long as the patient is supine. But you can turn them on their side, but then they cannot be up as far as 60 degrees. And you need to change the level of the transducer to make sure that you're doing this appropriately. There is a non-invasive cardiac output piece of equipment. This uses electrodes on the skin to send low voltage, high frequency electrical current to detect changes in the thoracic aorta. There's a table about this on page 355. This will also give you data about the stroke volume, so that's good. We also have a minimally invasive continuous cardiac output monitor, and there are 3 different forms for this. The first is the pulse contour waveform analysis produced by a company in London, England. This requires an ART line and an IV line. This will inject a small amount of lithium in the IV line to calibrate it, and you need to recalibrate this every 4 to 8 hours. Not 48, but 4 to 8 hours. And remember, lithium is given to patients that are manic, so if you do this an awful lot, you need to make sure you're using just a small amount of lithium, because it can make your patient depressed. Your pulse contour cardiac system output was developed by a company in Munich, Germany. This requires an arterial line and an IV line that has to be at the jugular or femoral site. This will inject cold saline to calibrate it, and it's to be recalibrated every 4 to 6 hours according to the company. According to people who use it, you may have to do it at least every hour. Then they have the Vigiligo monitor, and this was produced by Edwards Lab in Irvine, California. This requires an arterial line and specialized sensors that are placed on. Now, there are conflicting results about this as to how well it works, but it does not require any calibration, which is maybe one reason we're having some problems getting an idea about how well it works. But the nice thing is it can go from patient to patient, as long as they have an arterial line in. An esophageal Doppler is done if your patient is under anesthesia or deeply sedated, and then they place the lead at T5 or T6 to look at the heart. You've also got a partial carbon dioxide rebreather piece of equipment. To use this, the patient must be vented. They use a NICO system that's required, and it requires frequent calibration. Again, the results with this are very inconsistent, so they really don't know for sure how well that works. Your arterial line, the purpose is to continuously measure the blood pressure, your mean arterial pressure, and or just to get blood gases if you have somebody who's on a ventilator and you're doing frequent vent changes. The equipment you're going to use is a Teflon-coated catheter, high pressure tubing, again because this is in the arterial system, a transducer, and a flush system with heparin. You'll also have a bedside monitor. In order to do this appropriately, you have to do the Allen test first to make sure that if you're going to occlude the radial artery, that there's still blood supply to that hand, because we don't want our patients losing their extremities. Then you insert the catheter, which it can be like a 20 gauge Gelco or 20 gauge over the catheter needle. It is connected to the flush system, which we've already talked about. You level the transducer again And then you analyze the waveforms. You'll have a waveform for systole and then diastole. Now diastole, when you look at the waveform, you'll notice that the wave that comes down will have a notch in it. That's called a dicrotic notch. That is the beginning of diastole. And then you get your mean arterial pressure. Now your mean arterial pressure is your systolic plus twice your diastolic divided the total by 3. This will give you your average or your mean arterial blood pressure. You need to have a mean arterial pressure of greater than 60 to perfuse your coronary arteries. It needs to be between 70 and 90 to decrease the workload for that left ventricle. And if you have somebody who's having neurological surgery or an carotid endarterectomy or any type of head surgery, then your MAP should really be between 90 and 110. Now your pulse pressure is something else that you can do, and that's taking your systolic blood pressure, subtracting your diastolic blood pressure, and coming up with a number. We've talked about this. This will indicate low blood volume. Remember that your arterial waveform, if you're looking at it with your EKG, will follow the EKG. Now your waveform, again, your pulsus paradoxus, we've talked about this. This is a decrease of more than 10 millimeters during inhalation. This can indicate cardiac tamponade, pericardial effusion, constricted pericarditis, or hypovolemia. Your pulsus alternans is when every other beat is weak, and this indicates left ventricular failure. A dampened waveform, there's a figure on page 333 that shows you what a dampened waveform looks like. There are also figures on 329 and 330 that show different waveforms for the arterial system. If you're having problems, there's a table on page 331 to 332 that lists all the different problems, such as clot formation. That's why they've got the solution has heparin in it so that you don't get those clots, but sometimes you do. Hemorrhage, particularly if it becomes disconnected. Air embolism, loss of the waveform, or a waveform that does not correspond with the digital readings. There is a table that talks about the different pressures and calculation of your hematologic values, and that's on page 327. Central venous pressure, the purpose of this is to identify filling pressures in the right heart, your patient's hydration status, or to look at your right ventricular and diastolic pressure. It is not good for looking at left ventricular dysfunction. You can do this with the head of the bed elevated 0 to 60 degrees. The normal is 2 to 5 millimeters of mercury. Remember, your wedge pressure is 5 to 15. That's when you're using a transducer and a monitor. If you're doing a manometer and water, then that's 3 to 8. Again, you have to identify that phlebostatic axis, because if you're too high, this will be too low. And just as it would be for your swan, you need to make sure you've got that at the phlebostatic axis, which is your mid-axillary line. If you're trying to convert somebody who's been on a transducer with a monitor to someone who's going to be using a manometer for readings because they're no longer going to be in the acute care unit, 1 millimeter of mercury equals 1.3 centimeters of water. And if somebody has a central venous pressure line in, you can do this with the distal tip of your central line, because this will be located in the right atrium, and they can sometimes be removed by the registered nurse if necessary. Your mixed venous oxygen saturation is also known as SVO2 monitoring. It's figured by taking the oxygen not used minus the oxygen that's used, and this gives you the amount of oxygen that's bound in your hemoglobin. Your normal SVO2 is 60 to 80%. If 40 to 60%, you'll have an increased demand for oxygen. You may have a patient who has a decrease in cardiac output, a decrease in hemoglobin, or a decrease in your oxygen supplies. If it's less than 40, you have a problem at the cellular level, and you have a patient who is in lactic acidosis. The 40 to 60, you could have somebody who's being suctioned, has ARDS, or somehow or another has become disconnected from the ventilator. If it's greater than 80, you're going to have a decreased demand. So you could have somebody who's in septic shock, hypothermic. The decreased demand might be anesthesia, coma or conscious sedation, or maybe they're receiving supplemental O2. There's a figure on page 362 that lists the factors that contribute to SpO2 values, and a table on page 361 to 362 that lists the activities that alter your oxygen consumption. And as I mentioned, I've also included your AACN practice alert, your pulmonary artery pressure monitoring for you to look at. So please review that also. And that finishes this section.